So the next speaker really doesn't need an introduction. So the next speaker is Professor Jayaprakasan, and it's my privilege to introduce him, a leading authority in reproductive medicine and my subspecialty training supervisor. So Professor Jayaprakasan is a subspecialist in reproductive medicine and surgery, and he's the lead consultant for the fertility unit in the University Hospital of Derby in Burton, and is affiliated with the University of Nottingham as an honorary professor. He also works in care fertility as an IVF consultant. He's very research active. He supervises PhD students. He's authored many peer-reviewed research papers. We've lost count in fertility and gynae ultrasound, and has also authored textbooks and guidelines. He's internationally respected for pioneering work in fertility, imaging, ovarian reserve, and ultrasound-led diagnostics, with in particular the use of 3D ultrasound. So yes, Jay, if you're ready to go, then thank you very much for being a part of this.
Thank you, Emily. That's very kind. Let's move on. So I know Prof. Amar has already covered with regard to the endometriosis, so I wouldn't be touching at all on this, and Prof. Amar was the right person to talk on that. Let me just give you a bit of background with regard to the fertility point of view. Obviously, to achieve a pregnancy, the embryo implant in the endometrium, and it is a cross talk between the endometrium and the embryo and the endometrium. And of course, that is influenced by various other factors, like, for example, in an IVF setting, maybe the procedure of the embryo transfer would be influencing, and maybe the other aspects, whether it is a natural conception or IVF, it will be a tubal or peritoneal aspects, and then with regard to the immune system as well. And I'm not sure about this. Is something which is I picked up just a recent article by Nick Macklon. And you see, it is not always a sort of an absolute sort of a degree of quality, whether the embryo or the endometrium. It is actually, it's an interaction. Therefore, sometimes if the embryo is of a top quality, even if the endometrium is of a low quality, it can implant. And that is what we need to understand. So there are those who are working in fertility, how many times that we have seen that, oh, we have been chasing the thin endometrium, and suddenly they get pregnant with the 6 millimeter endometrium. Whereas on the other hand, if you see that 10 millimeter endometrium, and if you're putting absolutely perfect looking embryo and it doesn't implant. So there are so many things which may happen in that sort of interaction. And I'm not touching upon the physiological aspects, but let us look into the pathological aspects. And some of the clever people who have done some mathematical modeling and thought that the endometrium probably would be contributing about 40% towards a successful implantation. And there are various abnormalities that will be affecting the uterus and the adnexa as well. So as you see, the pictures clearly demonstrate that. So the endometrial pathologies that you'll be looking at, the uterine anomalies. You can see it's a septum there. There's a polyps, then fibroids that you see, and intrauterine adhesions, and the adenomyosis, and you will see the hydrosalpingo. So these are the sort of possible abnormalities which causes reduced fertility. And it is not just achieving a fertility, it is basically that we'll be looking at further reproductive outcome, because you need to make sure that once they become pregnant, they have a good and normal outcome. So that means, no increase in miscarriages and no increase in preterm delivery and things to achieve a healthy baby. So let us move on to the uterine anomaly first. And if you are looking at the prevalence of uterine anomalies, it is not uncommon. And, we did this systematic review and meta-analysis some time ago now, probably more than 10 years now. And you see if you just focus on the last column, you see in an unselected population, the prevalence of uterine anomaly was about 5.5%. And fertility, it is slightly higher. If it's a miscarriage, it's about 13%. And if it's a mixed infertility and recurrent miscarriage, it is about 1 in 4 women who have had a uterine anomaly. And this is something which we did, again, a prospective study where we used the 3D scan for all the people who have come into the fertility unit prior to IVF, and you see the prevalence of uterine abnormality was about 13%. And if you look at the major abnormalities, so majority of them out of 13, majority of them were arcuate. And most of you know that arcuate is a subtle dip in the fundus. And nowadays it is considered as a normal variant. So if you're looking at the major abnormalities, not major in the sense that what I mean is significant uterine abnormalities, about 1.5% of the population had some sort of a uterine abnormality, and out of that 1% of the whole population had a septate uterus, which is the one that we commonly see as a uterine anomaly. And the laparoscopy and hysteroscopy as a combination helps in terms of clear diagnosing the uterine abnormality, because the hysteroscopy will help us to see what is internal contour, and the laparoscopy will help us to see the external contour. So if you see that this is a combination, then you all agree that it is a normal uterus. Whereas if you're seeing the one in the middle, that is could be a septum or it could be a bicornate, but you need to see the outer contour, because if it's a combination of these two, then you say it is a more of a septate uterus. Whereas if you're seeing something like this, then it is a bicornate uterus. And this is quite important in terms of diagnosing, because if you're just doing a hysteroscopy and if you're going and dissecting this, and if you're doing that in a bicornate uterus, you are straight into the abdominal cavity. So that will damage the bowel. And this one is clearly showing the hysteroscopy. On hysteroscopy, it's a unicornate uterus. So you need to see the internal and external contour of the uterus. And traditionally, we have considered this combination of hysteroscopy and laparoscopy as a gold standard. But since the 3D ultrasound that provides the coronal plane, which is a front-on view, it gives the external contour and the internal contour, and therefore the 3D is now considered as a non-invasive gold standard diagnostic tool in terms of diagnosing uterine anomaly and also clearly classifying what type of uterine abnormality it is, because it is important to diagnose what type of uterine abnormality, to counsel them in terms of what the risks are in any reduction in conception or fertility problems, or any increase in the miscarriages, preterm labor, and malpresentation. And if you see the fertility problems, generally the septate or subseptate uterus has shown that reduced fertility, whereas all the others, there isn't any evidence of reduced fertility. This is also one of the systematic review and meta-analysis that we have done some time ago, along as a series of things that have done in uterine anomalies. Whereas the majority of the abnormalities causes either the first trimester miscarriage, the second trimester miscarriage. In fact, almost all of them increase the risk of preterm labor and malpresentation at birth. And if you're diagnosing it, if you're treating it, does it improve the outcome? So in the septate uterus, the meta-analysis has shown it doesn't. If you're doing a division of septum, it doesn't increase the fertility, but it has shown that it reduces a miscarriage. And we must remember, these are all controlled studies. None of them are randomized controlled studies, but it's a controlled study where it could be retrospective, and some of them are prospective. There is only one randomized controlled trial. It is always extremely difficult to do any randomized controlled trial in any surgical situation, because of difficulty in recruiting, difficulty in convincing even the professionals as well. Whereas we should congratulate this Dutch group, who they have taken about 10 years to recruit in the uterine anomaly in the septal division study that it's called TRUST trial. In fact, they have 10 centers, and they have included women with fertility problems, women with miscarriage and preterm labor with the diagnosis of uterine septum. And they haven't shown any improvement if you're dividing the septum in terms of achieving a successful pregnancy. So the only randomized controlled trial hasn't shown that there is any benefit. We did a scientific impact paper on behalf of the RCOG. In fact, this is published this year. And based on the evidence base, we just wanted to highlight that. And in fact, this is what we need to tell patients as well. Most women with congenital uterine abnormalities experience normal reproductive outcome. However, there is an increased risk of adverse outcome, miscarriages, preterm labor, depending on the type and degree of severity. And for women with a recurrent miscarriage, the hysteroscopic division of septum may be considered on an individual basis by experienced specialists because of probable benefit in these women. However, in fertility population, if you're diagnosing an incidentally diagnosed septum, the treatment is debatable and needs a further study. And I just wanted to highlight to you, this is one of the cases that we have treated probably about 2019 time, a young lady who has come with fertility problems, and we did a scan, and you can see it's a complete septate uterus. And then she had an HSG with applying the catheter into both the cervix. So you can see there is two cervical canals because septum is dividing the cervix. And after putting the catheter, injecting a dye, it was demonstrated that the tubes are patent. And then what we did is, obviously, we discussed about all these things, and we said we could do an IUI. Those days, the IUI was funded. And we didn't do an ovarian stimulation because we wanted to avoid multiple pregnancy, because there is an increased risk of miscarriage, and that is the worst thing that we could do to have a multiple pregnancy. So therefore, we went with a natural cycle. So it's a monofollicular response, as you see there, and then did an IUI. And the first 2 cycles were unsuccessful, but in the 3rd cycle, she had conceived, and you can see it's a successful pregnancy in the right uterine horn. And then she had a baby at term. She had a cesarean section because of breech, malpresentation, and then had a baby weighing about 2.6 kilos. So this is just to demonstrate that we need to still remember most people will have a normal outcome. So how do you go ahead with the septum in case if you're going ahead with septal division? So in our practice, what we do is 3D ultrasound, and then you measure the septal length. So you draw a line along the tubal osteate one side to the other side. It is the interosteal line. And then that is your reference line, and you measure the length to the bottom of the septum. And if this septal length is more than 10 millimeter, that is a septum. If it is less than 10 millimeter, you class generally as a more of an arcuate uterus or an insignificant septum. And in those situations, so you know that what is the length of septum, and then you do the surgery. Previously, people used to say that you do a laparoscopy as a guidance, or an ultrasound used as a guidance. But because of 3D, we will be able to know clearly what is a septal length. And see, there are a lot of options that you can see. Generally, you could use a loop, or you could use a needle, a diathermy needle, or use a mechanical scissors. One advantage with the mechanical scissors is you are not using a diathermy, and therefore the damage to the endometrium is less. But having said that, in my practice, majority of time we see a thick septum, and it is very difficult to divide using the scissors that we have. And what we nowadays do is we use a bipolar needle. So you can see this one, which is quite easy to use. VersaPoint. So you can use a 5 millimeter hysteroscope, the routine routine hysteroscopy that we use. And this is, you can insert that and then divide this into using this bipolar needle, VersaPoint. And we generally don't give any GnRH. I used to give GnRH agonist injection, but that makes things a little bit tricky to time it. And for the septum, generally it is quite easy to see, provided they are not bleeding. And then after that, there isn't any evidence that we can do something to reduce the risk of adhesion between the 2 surfaces where we divided. But having said that, what I tend to give is we give the hormones. So like estradiol, valerate 2 milligram 3 times a day for about 6 weeks. And then the last week I give progesterone, medroxyprogesterone acetate 10 milligram once a day for about 7 days, and then have a bleed. And generally, I tend to do an outpatient hysteroscopy after 6 weeks. So in case, after we divide the septum, and if there is a small adhesions at the top, then we could divide that using a simple scissors. And at times, just in case if it is really a long septum, I tend to insert a balloon. And this is a kind of 8 French balloon. You cut the tip and then put that in, and then you can leave it for about 3 to 5 days, but generally tend to give antibiotics, a broad spectrum antibiotics to reduce the risk of infection. The polyps, easy to diagnose. I'm not going into the aspects of the diagnosis. With regard to the fertility impact point of view, there isn't any robust evidence. We have done a Cochrane review some time ago, and there was only one randomized controlled trial in an IUI population. And what they have done is they've randomized into either hysteroscopy and a polypectomy, and the other one is just hysteroscopy and a biopsy. And look at this success rate. It has been extremely high in the polypectomy group, too true to believe. And therefore, in the Cochrane review, this study has been excluded. So there isn't any sort of evidence. I know currently there is one study which has been proposed, but I think the team are struggling to recruit for that. So polyp point of view, there isn't any clear evidence. But having said that, if anybody who is coming to the fertility clinic, it is routine practice because the removal of the polyp is generally a simple procedure. And majority of time that we can do as an outpatient, like this video that you're seeing, it is a TrueClear that we are using here. And I'm sure most of you are familiar with the TrueClear morcellation, and the polyp is quite easy to remove. And then if there are various other ways as well, you can use scissors, polyp forceps, or in fact, even you can use the resectoscope as well to remove the polyp. Moving on, fibroids. Fibroids is also even more difficult. I mean, this is something that we do commonly see, and generally I tend to say that, at the age of 30, probably 30% of women have got fibroid. At the age of 40, around 40% of women have got fibroids. And in terms of the impact on fertility and the reproductive outcome, it depends on where it is exactly located. And I'm sure most of you are aware about the FIGO classification. And you see it is stage 0 to stage 1 is a sort of stage 0 to stage 2 is submucous fibroid. So stage 0 is completely within the uterine cavity. Stage 1 is more than 50% in the endometrial cavity, and stage 2 is less than 50% in the endometrial cavity. And if you look at the evidence for the submucous fibroid, I'm not showing the data, but there are a number of meta-analysis systematic reviews have been done. And submucous fibroid, it says that it affects fertility and it increases the risk of miscarriage. And intramural fibroids, it does affect fertility and increase the risk of miscarriage, regardless of size of fibroid. And the subserous fibroid, it is away from the endometrium and it doesn't affect the fertility. And what about the treatment? Then, as Saad mentioned, like in endometriosis, particularly, here also the evidence is very, very weak. And that is mainly because there is only one study on looking at removing the fibroid and looking at the outcome. And even that, the numbers are very small. But that study has shown that submucous fibroid, if you treat, there is benefit in terms of improving fertility and reducing the miscarriage. And whereas the intramural fibroid, it is very unclear. And there are no randomized controlled trial, but there are some controlled studies which have shown varied findings. And subserosal fibroid, there is no difference in terms of benefit. And I'm sure in our practice, we generally see when we are seeing submucous fibroid with the fertility problems, invariably we get on with a removal. And with regard to the procedure point of view, obviously need to have trained in terms of the operative hysteroscopy. And generally, I tend to give for submucous fibroid, giving 1 or 2 doses of GnRH agonist, or even a little bit longer, depending on the size of the fibroid. And the advantage is that tend to make this fibroid smaller, and also the endometrium becomes thinner and less likely that and women will be bleeding when we are going ahead with the procedure. And the other thing that I tend to do is to give some misoprostol, because majority of them that we do with the resection of fibroid would be nulliparous and cervix will be very narrow. So giving the misoprostol generally about a couple of hours before, that makes this the dilatation a little bit easier and potentially reducing the risk of perforation. And with regard to the myomectomy, the intramural fibroids, one of the things that we do is generally if the fibroids are less than 5 centimeters, we wouldn't generally go ahead with the removing the fibroid. But if it is more than 5 centimeters, then yes, tend to go ahead with the myomectomy for the fertility reasons. And of course, that if they have got symptoms like heavy periods or pressure symptoms and 2 large fibroids, and then yes, tend to go ahead with the myomectomy. And regarding the laparoscopy and laparoscopy versus laparotomy, it depends on the individual circumstances. And there are smaller fibroids that people tend to use most later, like the TrueClear that I've shown. We don't tend to use this mainly because of the lack of instrument. But although if it is a very small fibroids, like less than 2 centimeters submucous fibroid, then we tend to do that as an outpatient procedure. One advantage with the morcellation is because you're not using any diathermy. What about the evidence base in terms of the procedure point of view? In fact, there is one randomized controlled trial, I must admit, that is featured in this systematic review and meta-analysis. And you see that the numbers are very, very small, and that hasn't shown any benefit even in submucous fibroid. And there is a call for a trial which is going on, but again, recruitment is difficult. Quite a number of you would have heard about the Sonata, which is a radio frequency ablation. But the data on fertility is very limited. In fact, when this was introduced, they haven't done the study in women who are seeking fertility. But having said that, there are probably nearly 100 pregnancies have been reported without any problems. But one advantage with the Sonata is you're not damaging the endometrium, and probably you're not weakening the myometrium as we do in myomectomy. So again, a personalized approach to manage fibroid associated with fertility, and depends on the location, size of fibroid, and what is their previous outcome, and whether they have got any fibroid-related symptoms. Moving on, what about intrauterine adhesions? Generally, the diagnosis is symptoms, amenorrhea or oligomenorrhea. And if you're doing a scan, generally the endometrium will be very thin, irregular. And in case if you're scanning, at times scanning during periods, you might see that in the bottom picture, you can see some menstrual blood with the adhesion. So, and if you're doing a saline infusion sonohysterography, see, just put a bit of saline, and you see the band of adhesions between the anterior and posterior myometrium. So that's good in diagnosis, but of course that the hysteroscopy is a gold standard in terms of making a diagnosis of intrauterine adhesions. And the ASRM has come up with the grading that depending on the cavity, how far the cavity is involved, whether it is less than 1/3 or 1/3 to 2/3 or more than 2/3, and type of adhesions, whether it's filmy and dense, and the menstrual pattern depending on the symptoms, and they've categorized that into stage 1, stage 2, and stage 3. And this is an example of mild or stage 1 adhesions, as you see here. And at times, if you're doing a HSG, which is a routine practice in our unit sometimes, those who are coming for fertility reasons, of course, and you will be able to see some filling defects, giving an indication that that could be intrauterine adhesions. And majority of time, if it is a mild intrauterine adhesions, even just doing a hysteroscopy would be helpful. And you just move the hysteroscope from side to side, and that improves the outcome. This is an example of a bit of moderate adhesions. In fact, this lady was referred to us because of suspicion of a submucous fibroid. But when we did the hysteroscopy, this is what we have seen. And you can see it is more of as per the ASRM, it is more of a moderate adhesions. And these are all released with scissors. And in the end, with all intrauterine adhesions, I tend to put in a balloon. And we used to have the Cook's balloon, which is a triangular, which some of you would have seen. But something that we have experienced is it's very difficult to remove it. And also, of course, that it is difficult to get it as well. Whereas this one is quite easily gettable. This is only a pediatric 8 French follies. And you can cut the tip of this, and then put that in and instill about 3 or 4 ml saline, and we'll leave it for about 3 to 5 days, and then giving antibiotics to reduce the risk of recurrence. There isn't any evidence of this that reduces, but still, and we give antibiotics. And as I said to you before, for the septum, same thing like estrogen and progesterone for about 6 weeks, and do a check hysteroscopy after 6 weeks. And if there is any recurrence at that time, then we just, again, it is easy to release at that point in time. And if it is severe, then again, it is quite tricky. And of course, that we'll have to use an ultrasound guided approach with this. So you can see here when you're going in, you don't know where exactly you're going in. And therefore, the ultrasound actually helps which direction that you have to put the scissors through. And that helps in terms of this. But of course, that if it is beyond our remit, then we ask the experienced people to do it. So that is something that we'll have to look into. This is something that if it is a mild intrauterine adhesions, that I tend to do even just putting the balloon itself will actually expand the uterus by 360 degrees, and it helps in terms of releasing some minimal adhesions. In fact, this is something that I learned from Sotris Saravelos, who is actually speaking on AI in infertility. I don't know whether he's here, but he's the one when we were discussing, and he's the one who said of this observation. And I have had a good success if there is a very minimal adhesions with this. This is a hysteroscopic tubal cannulation but I must admit this is something which has gone out of fashion, because if the dye test, if it's not showing, then generally nowadays people are going directly for IVF, and therefore this is bypassed. And on top of that, we used to use a Cook catheter for hysteroscopic cannulation previously for any proximal blockage. And now that I have used a couple of cases where the ureteric stent to pass through, but unfortunately the ureteric stent is a little bit more stiffer. I hope I'll take only a couple more minutes. As there was a discussion about cesarean scar niche before, so I thought I have added a couple of images. So this is a lady who has been referred because when she was having frozen embryo transfer in one of the nearby IVF units, but when they were prepared to put the embryo in the endometrial cavity, they were fluid. And if you carefully look, I don't know whether you can see here, if you carefully look, there is a cesarean scar niche. You can see the fluid is actually flowing into the scar niche, and then it comes back. And this may well be the reason why she's having a secondary subfertility, because in a natural conception, at around the time of implantation, this fluid is going up and down, and therefore it might be washing out. And maybe it might be toxic for the embryo. And this is again showing in this video as well. And when we did the MRI, you can see quite a deep defect. And this lady had a successful cesarean scar niche using a combination of laparoscopy and hysteroscopy, and then she had a conception following an ex-frozen embryo transfer. And then the treatment depending on the residual myometrial thickness. So if you measure the residual myometrial thickness, and if it is more than 3 millimeter, you could actually shave off the bottom bit here, and therefore you're removing that niche. So whatever the menstrual blood which is getting collected, that will be coming out, and thereby reducing the chances of the fluid collection within the cesarean scar niche. Then just last slide, second last slide. The hydrosalpinx is certainly, there is clear evidence of the hydrosalpinx potentially affect the chances of IVF outcome, and that is based on Cochrane review, as I have shown you here. And there are various ways that we can treat the hydrosalpinx. One is a salpingectomy versus no treatment, and the other one is there are various other things like salpingectomy and tubal occlusion, even ultrasound guided aspiration as well. And in this recent meta-analysis, even categorizing them into type of surgeries, salpingectomy versus no treatment has shown higher chance of ongoing pregnancy, and more or less similar, sort of, not to the extent of the degree of, you see the odds ratio about 4.35 here, whereas ultrasound-guided aspiration, the odds ratio is about 2.8. Ovarian cyst removal, depending on the size of the cyst, majority of time you will see it's a simple cyst or a hemorrhagic cyst or an endometrioma, which we have already heard from Professor Amar, or a dermoid. It's usually in an IVF context, if that is causing any problem in terms of the egg collection, then yes. Otherwise, if you are getting on with the IVF, try and not to injure the dermoid or endometrioma, because otherwise it increases the risk of infection. But of course, if you're seeing these fibroids that we have operated recently, but very large fibroid, but in those, dermoid, and in those situations, of course, that you will have to go ahead with the surgery. So as a conclusion, I've shown you that the uterine abnormalities and adnexal pathologies can affect the reproductive outcome, and I've categorized them into like the HFEA traffic light system. That the evidence for certain conditions, like is green, which is for hydrosalpinx, that there are randomized controlled trials which have shown that there is a benefit. Adhesiolysis, although there aren't any randomized controlled trials, that pathology speaks for itself, and we tend to treat it. There is somewhere in between, like myomectomy, polypectomy, division of septum, and ovarian cystectomy, depending on the individual circumstances. Adenomyosis I haven't gone into, but generally there are, in Europe and other places, people do treat adenomyosis. But obviously in our practice, it's more of a red. And surgery for bicornate uterus and uterus diadelphys, probably we wouldn't recommend doing any surgery. Thank you very much. I'm happy for taking any questions.
Yeah, fantastic talk, Jay. Thank you very much. I have one question in the chat for Madhavi. If you want to put your camera on and your
You're on
mic on
mute,
and ask Prof your
Emily.
question. Oh, pardon? Am I muted?
No, I can hear you, Emily. That's fine. Carry on.
Still on mute?
No, I
No.
think no, you can hear me. So yes, there's a question here from Madhavi. If you want to put your camera and mic on, if not, I can ask it for you.
No, I think it's me because I kept my. Yeah. Fine, I can hear.
Yes,
Sorry.
go on ahead.
Thank you, Prof. Very clear presentation as always. Just wondered your view on uterine artery embolization for fibroids.
Thank you. The uterine artery embolization is certainly not a first-line recommended option for fertility reasons, because there is clear evidence. Sadhanai and other people, we have done meta-analysis of the effect of uterine artery embolization on ovarian reserve, and that has shown that it affects the ovarian reserve and it affects the fertility. And certainly the concern is on the uterus itself as well, it reduces the blood flow and therefore potentially problem with, fetal growth reduction and preterm labor and probably the placental problems as well. But having said that, there are hundreds of successful pregnancies have been reported. So this is something which we do commonly, isn't it, when we are practicing? And I tend to say to patients that this is not the first line recommended treatment, but of course that as an option we do discuss. And there are some patients who wants to avoid any surgery, and therefore they do opt. In fact, I had one patient this week. She opted after discussing with all these options for the uterine artery embolization.
Thank you.
Great. If we don't have any other questions, we'll move on to our next speaker, if that's okay, Professor Jayaprakasan. So